The goals of this lecture is to show what the obvious record keeping should be. We're going to talk a little bit about HIPAA, and if we have enough time, we're going to talk about truth in advertising. The objective, of course, is to present the basic information that all dental records must have to meet the standard of care and record keeping. If you listened to Dr. King yesterday, you found out there is no SOC. Boards do not put down a standard of care. They don't tell you that. In fact, not only don't they tell you that in writing, but they'll tell you later that you didn't meet it. So I always, whenever I lecture to our group, I always want to make a mention of Ed Arana, because this conference always puts him in my dreams and heart, and may he always live forever, because what he gave to us was a star to reach. We may never reach that star, but we're on our way there. There are many types of different record keeping, from pegboard to computers. Every one of them must address these topics. We're going to talk about individual records, record keeping organization, documentation of recall, maintenance and record purge, record confidentiality, which is a big one, and then record review and quality assurance, and access to information, and these are guidelines from Cigna Insurance Company, and also we got to know a little bit about HIPAA. I don't know if I have a slide in here later on, but now in 27 different states, if you're dispensing vitamins as a dentist, you have to give an explanation to the patient of what you are dispensing and why in the United States. Okay, let's talk about that individual record. You have to have a separate one per patient. All patient personal information will be there. Written and dental medical information has to be there. All diagnostic records, radiographs, diagnostic photos, and referral correspondence. And if you're doing a full reconstruction, I would say your models need to be kept. All medical tests, all proposed treatment, and signed consent forms. And no commingling of family records. Before I became a dentist, I had a master's in business, still have that master's, but I used to go into offices where doctors were a little on the cheap side. They would have a family record with every member in that family all commingled in there because it was less money for them to do. Not a good plan. So what we did, we organized our things, which is the foundation of all offices. A pleasant working environment for doctors and staff. What's it like when a patient comes in and you can't find their records? You want to see my staff go crazy? You want to see them go nuts? Guess what? If they can't find a record, of course we know it's the doctor's fault, because number one, he's the doctor, number two, he's a male. Now, I don't know what happens when it's a female doctor, because it can't be her fault because she's a female and the doctor. But if you're a male doctor, it's always your fault. Patients will sense and appreciate efficiency. They will love walking in and want to come back to you if you're organized and you know what the next appointment is. So what's the last thing you're going to write in your records? Next appointment. Make it very, very clear. And then better acceptance of treatment plans. You'll meet their financial obligations and commitment to you, and you'll be able to pay the staff. They like that. So what happens next is you choose an expandable folder, organize it in a rational manner, alphabetical order, color tabbed, file folders and storage retrieval, rules for staff handling of records, and a letter of patient and patient record confidentiality agreement in your office manual to hit HIPAA regulations. We have an individual that comes in once a year, and everybody has to sign the book. And within that book, it has an obligation by my staff to be confidential with all patient records, and that they will not take any records out of the office, and they agree to act professionally. All three of those things are in your OSHA standard book. If you don't have an OSHA standard book, you're practicing outside the standard of care in the United States. And you got to train your staff. You got to train them how to handle records. Now, I'm very blessed and lucky. I have two of my hygienists here today, and they keep excellent records. They put down if there's a problem. They put down communication with that. And they put down what we've decided what their periodontal condition is. All written out very clear, every visit. And they make sure the x-rays are up to date. In fact, it's checked by the front desk, by the hygienist, by myself, and the assistants. One of the four of us is going to get it right. So, original dental records and diagnostic records must remain in the office. If you got to work on a record, copy it and bring it outside. Don't remove that record from your office or stay there and write it up. Train all personnel on how to handle records. Before I had this present staff, I had a staff that they liked the printed letter so nice that they kept the original. They would send out the copy because it didn't look so nice. This one assistant was so good that she knew somebody by George or by Bob. So how did she file the chart? You got it, by George and Bob. It wasn't their last name because they didn't know who the last name was, but they knew George and Bob. It might sound silly, but that's very important to realize that they have to know that you've alphabetized by last name. And your staff should sign a letter of professional conduct and understand concerning patient and patient records confidentiality agreement. We have a very interesting situation in my office where I actually have an employment contract with patients, and we figure out what they get paid and all that other stuff. And in there, that's what's signed on my other staff members have to sign that confidentiality. And that's in backup with our HIPAA regulations. So you want to document recall. Don't allow your patients to fall through the cracks. Now, I might be talking to dentists here, but if you are a homeopath, or if you're a naturopath, and you have patients, you should always have a recall wellness appointment for these individuals, just to make sure they're doing well. And yes, you do charge for it. And you want them there, and you want, before they leave, and you're going to see this at the end, that you sign next visit, wellness check. Well, we call it a periodontal examination or a recall. Keep the record of contact and any attempts to contact the patient. Dates are listed in a logical, retrievable place. If you're on a computer and your girls or your front desk, I shouldn't say girls because there are a lot of men working at the front desk these days, they call the patient, enter it into the computer. You can do it under transactions as a phone call. Doesn't mean you have to charge for it, but it's retrievable. And this way, if somebody says, hey, they abandoned me, they never tried to reach me, you can pull it up on the computer, print it out, walk it into the state board and say, here it is. Now, if you don't have a computer that you're working with and you're just doing a pegboard, enter it in the chart. Tried to contact patient, called this number, put the number down, got the message machine, asked them to please call the office, have the person sign and date. And anything that you put into a chart, make sure you have a date. What's your office policy for missed appointments? Periodontal recall appointments in a timely manner. Reliability of patient following medical treatment, care, whatever you ask for them to do, their orders. Handling of difficult patients. A few years ago, we dropped this, but we used to have a PITA patient. You know what a PITA patient is? Pain in the ass, yes. And that we had with a big smiley face and PITA underneath it. So, anyway, what does a misappointment cost you? And establish a documentation individual recall interview for patients. Have your patient initial it, or have your staff initial it. Clearly inform patients of their need for recalls, and present a treatment plan that the patient signs if they accept it or not. I have patients say, well, I don't want to do that. I said, that's fine. You don't have to do that, but you need to sign here that we presented it to you. I can't make you make that appointment. Neither can my staff. You have to make the appointment. But if you reject my treatment plan, you can put down your name and put down do not accept. That's fine. That's all I want for my records. Doesn't mean that they don't like you and that they don't want to see you, but you have to have a documentation that you presented it to them. And please, determine what a no-show policy is. I had a gentleman miss a 2-hour appointment Monday, and I was flabbergasted. I couldn't believe that he was not at that appointment. And what happens? This individual is a great guy. I've lectured for him 4 times. He has a business in alternative medicine, and I've never collected a penny from it. He's in town. I don't have to travel anywhere. And this gentleman's missed 14 hours since 2003. I was unaware of that. So I made him aware of it by a nice little letter informing him, gee, what did this no-show cost me? I don't know about individuals here, but I can produce anywhere from $900 to $2,500 an hour. Multiply that by 14. I'm sorry, he's not worth that kind of friendship. He isn't. Neither are any of the other ones. You may dismiss a patient for noncompliance. I would send that letter out, registered receipt. And they usually come back unpicked up, but that's okay. You put it in your record that you tried to contact them, you called them, and everything else. And by the way, if you have a no-show patient, doctors, hygienists, nurse practitioners, you have free time, don't you? You were supposed to be treating that patient. So may I suggest that you call them personally and ask if they're okay? Because you know darn well they'd never miss your appointment because it's so important, and they wouldn't want to waste your time. It means a lot more to that patient that you called than your receptionist called. Take the 4 or 5 minutes that it makes. Okay, documentation of recall, periodontal needs, restorative needs, surgical needs, continued care, wellness check, IV care, exercise routine, etc. Whatever field that you're in, you should have a guideline for them that they need to continue and go. So your documentation for proper recall guidelines for patients are available. Continuality of care for each patient, proper recall intervals, quality of care by the individual to detect pathology, quicker response to treatment needs, especially with your periodontal patients. And document the number of missed recalled appointments before you refer to a patient to a specialist. That's one of my best ways of getting a patient out of the office that doesn't show up. I refer them to a periodontist. Why not? I had one doctor never showed up for an appointment. When I sent him to the periodontist that's charged 3 times the amount that we would do, he showed up. So cost wasn't the factor, it was the important factor. Plus, we got rid of the PITA. Ensures patients will remain committed to their proper home care. This is really what's important. Are they keeping up with their maintenance? Do they have their medical needs met? Are they following a good diet? Are they drinking water? One of the things that you can look at over in the exhibit hall, Dr. Zinus has got pictures of tongues. Tongues will tell you so much. Go over there and find out how you can tell just by looking at somebody's tongue if your patient's dehydrated. It is so simple, so easy. And yet the patient will come back and they'll show you their tongue every single time. Make sure that it's hydrated. Every patient that enters your office were to commit today to all their cleanings and all their programs, what would happen to you? You would have to increase the number of hours you work every week, increase the size of your facility, and or hire more staff people to meet the demand. Think about it. If everybody that came in as an initial patient never left, we would be so busy we wouldn't know what to do. And the same is true with nutritional counseling, exercise people, all medical forms. Why are we losing patients? This way, if you keep a record and you know, and if they don't come back, then you can either send a letter out, choose your market. As Dr. Brockman said before our break, look at where you're marketing. If you've already had the patient in the office, it's easier to get them back than it is to go find a new patient. So internal marketing is essential. How do you do that? You do it by purging your records. Individual state laws will dictate the number of years that you need to keep your records. Inactivated records should be purged and kept in a retrievable location. But by purging your records, you know who's there and who's not. And you don't have to waste your time trying to find somebody that possibly even moved out of state. You have off-site storage is acceptable, and alternatives to keeping paper records include computer scanning and microfilm and a paperless office these days. Any discarded record must have the patient's name removed for confidentiality. I went down this past month and I emptied out my storage place from records that I had from 1983. Okay? Cost me $500 to have them shredded. The guys say, we usually do this in 10 minutes. An hour and 10 minutes later, we were done with all my records. Shredded. So, but I also got from them a HIPAA confidentiality reliability certificate saying that they destroyed records from these 2 dates. So make sure when you destroy these records that you can prove that they've been destroyed appropriately or properly. Well-informed staff members know not to release records to anyone without a patient's written consent. And this sometimes gets very touchy with teenagers. Because when does a teenager become an adult in your state, and if their parents can request the records without the consent of a parent, or if the parent is allowed to get the records anymore? Our HIPAA, and that should be HIPAA, forms filled out properly. And then this includes spouse, parents of adult children, children of older parents, siblings, work associates, etc. And referrals to other health provider consultants. We have consultations with other doctors. We get permission in writing when they fill out the form that we can talk to a referring doctor. Because I had a patient one time complain that I talked to a doctor that referred that patient to me. I said, this is called communication. But they were upset with that doctor and wanted me to send them somewhere else. So on stage, off stage, this is really difficult in my practice because I have a bunch of goofballs. Ask the girls, they'll tell you all about it. The rest of the staff, except for the straight-laced dentist that we have as an associate, these girls are nuts. They're crazy. And they have to remember that they're on stage, off stage. You do certain things when nobody else is around, but I mean, these girls are cracking jokes, having a good time. This is a dental office. Are you supposed to have fun? I think so. It doesn't bother me, but some patients actually looked at me and asked if I was going to fire that girl because she was laughing. Believe it or not. Well, I have a very conservative group of people sometimes. We try to go through 150 to 200 random records on a monthly basis. That's not A, B, C, D, but she has an organized way of doing it. And then audit the following information. Organize or reorganize chart contents and record properly filed, and contains all non-treatment information, which is your insurance forms, etc. We're going to get into that. And then contain all diagnostic information, contents of all treatment plans, and all entries are legible, signed, and dated. Always make sure it's signed and dated. So what we do is we have the information in the treatment records, match the information in referral letters, informed consent forms, ledgers, insurance forms, make sure everything matches, and get the deletions and everything are made properly. All release documents are properly maintained, and if you release something, you have to record where you're sending it, what you're sending, everything else that is important. And then access to this information. The dentist owns the dental record and all diagnostic information. Now, HIPAA makes it a little more difficult because some people think that they own your records. You can get a copy and you can go ahead and charge them to reproduce that. Now, Dr. King yesterday said in Minnesota, you know, if the patient refuses to pay for it, you still have to send the information out. In Arizona, we haven't really had that problem, but I have had the state board turn around and tell a patient, it costs money to do these things, and the doctor isn't asking you for $1 million. $25 to reproduce your records is reasonable. And the patient was very, very upset about that they even had to pay because those were her records, not mine. By the way, she was a veterinarian. And dental and medical offices may be required to give patient a copy of these and an authorization form for them to release it. And so reasonable charges for that, and you go forward. Keeping the record straight, design your patient flow. You know, this is really important. You want to look like you're organized. You want to be able to go through all this, and we're going to go through each one of these steps to make sure that we know what we're doing. Office heading, have your date, patient's name, responsible party, adult for a minor, time that they sign in, any change in patient information you want on that information sheet, and management tool. Are we getting our patients back in time? Are we getting the patients so they feel like they're being attended appropriately, and what are the related costs of a no-show? And then you have your legal complications if you've ever been called into court because one parent says that the other parent didn't have a meeting. I mean, I've been called into court for divorce, custody issues a few times. By the way, this does not meet your HIPAA rules. This was a beautiful sign-in sheet. It was very simple. But it violates every HIPAA rule in the world. If you look at anything, look at this next slide, because here, Medical Arts Press has a form that when you sign in, it peels off, and this sheet stays on there, and at the end of the day, the staff takes it and takes the rest of it off, and we keep that in our records. Okay, so that meets HIPAA regulations for privacy. Now, the importance of the sign is it provides the patient was here at your office. There's a cross-reference for date sheets, child custody issues, tax audits, slide number 37 we'll get to. And then your patient information identifies your office. Welcome, thank the patient for being there, and you take care of them and that they trust you to be there, and you have your patient information form, responsible party, date, etc. So we welcome everybody, and we say there's my name, and there's a symbol that people can recognize, and we thank them for selecting us, and we're happy to help them out. If a patient has any problems, the girls will always ask many of the older patients if they need help writing or whatever. And so what happens is, who are you section. This tells us the special notes we need to be made that are private but accessible to you and your staff concerning anything special about the person. And confidentiality is paramount again. So you come in here, section 1, you have this information placed in there, and now you're going to go down, does the patient give you permission to contact them at work? Some patients do not want you to call them. Well, this past week we decided what we were going to do is we were going to get mobile phone numbers and have that with the patient permission to have that as their primary spot to contact them, because the guy who missed his appointment Monday had a very serious skiing trip that he went on for 3 days and blew me off. Had we had his phone number and we had his mobile, we could at least left a message, and I know he checks his phone number all the time, and we could have gotten somebody else in there. Okay, employer information, who referred you? Really important, because if you got a good patient, they really usually 99% of the time send you another good patient. If you got a really bad patient, guess what, they're going to refer you. So contact person in case of emergency, and is the patient a minor or responsible person or party? And the problem that you have is you have to make sure that if a child's dropped off, if you have permission, legal permission to work on them. And this is basically what the information sheet shows and all that information that we went in there. And always ask, who is the person to contact in case of emergency? Is this mom, dad, lover, husband, boyfriend, whatever? Doesn't matter. You just have to know their relationship. And you're going to have the responsible party information and their insurance information and who's responsible for payment. So you want to go in there and you have that information there, a driver's license, some identification, and information on the bottom there. We, by the way, do not keep credit card numbers or anything on file because of confidentiality. We'd rather take it over and over again instead of keeping it there, so if anybody were to break into our computers, that we wouldn't have that kind of information available. On the front page, that's basically what it looks like. It's nice, clean, it looks professional, people like it, and makes them warm and fuzzy. Here's the part that I hate the most, but unfortunately we deal with. It gives you the information for your insurance. And we have additional information if you have another insurance, and all that information goes in there. But insurance, every patient with insurance needs an insurance information sheet. Your staff member shall call and confirm the following information: eligibility, type of coverage, etc. And this is a form that we really like because it gives us a quick verification. The hygienist can look at this, our chair sides can look at it. They can tell us if there's a spot, if something like a night guard is covered, it will tell us percentage. So what happens is when they call in there, they put the phone number and the person that they contacted up here and the date. And that's our insurance girl. And Jody, you don't want to mess with, because Jody is 8.5 months pregnant, and she is not in the best mood when she's 8.5 months pregnant, but she is a detail person. I ask her to do something once. Don't ask her to do it twice, because you repeated yourself and wasted her time to do whatever job you asked. But she has it organized. She has the patient information here, the carrier, and if she has subsequent phone calls, she makes notes here or turns it over and puts the date, the person she called, the phone number, the extension, and what was discussed, all on this sheet. And it gives you a quick cheat sheet to know exactly what's going on, mailing address, and any other notes that she may have. So the insurance form summarizes waiting patient for the big three: preventative, basic, and major work. And who did he speak to, adds the direct line, date, time, all the details. And that's done every time she does it. She wants to know the effective time, the calendar year, year maximum, deductibles for family individual, was it met for that year, exams, bite wings, how often do they pay for that, the history. All these other things are all summarized up on that piece of paper. You can do the exact same thing if you do this in a medical form. You can take whatever services that you have, if there's eligibility for it, what percentage they're going to pay, or if they're going to pay anything. we have the patient's initials and dates on this, and we also put there, to avoid misunderstanding regarding dental insurance, we wish persons responsible to know that all professional services rendered are charged directly to them, and that they are responsible for payment of fees. We will prepare the necessary work, etc., upon receipt of full payment of the bill. We do not render our services on the basis that insurance companies will pay all our fees. Each fee is individual for the individual patient. They sign and date that. And then down here, it goes into more details. I understand there will be a $25 charge for every half-hour appointment missed, $50 per hour. And we're going to be changing that and raising that double that amount because it's ridiculous. If we have a new patient that comes in, and we get a lot of new patients from out of state, and one of the things that Dr. Brockman said in her last lecture is, how soon can you get people in? Unfortunately, we can't get everybody in the next day. And so what we do is we take a down payment of $100 an hour. If they have a 2-hour appointment, it's a $200. And if they don't show up, we have that. And it's taken with a credit card, and we will charge it. We also have, with all accounts wherein payment is not received within 10 days of the date, etc., we have a 1.5% per month charge, outstanding bill or balance. In the event it becomes necessary to place this account for collections, the undersigned agrees to pay in addition any amounts due and owing reasonable cost of collection. So we have all our legal wording in here, and I have used that. I had one patient tell me I didn't know what I was signing. I said, that's unfortunate, isn't it? So, that goes forward, and unfortunately, we're running a business here. So the medical history, initial visit, physician name, date of last exam, any illnesses that we need to know. Are you under medical care? History of operations, take medication, either prescribed or over the counter. On many of the new patients that come in, they have medical information that can go 3-4 pages. I actually ask the girls to ask the patient to type it out, so I don't have to write everything out. That takes up the whole appointment. So if you have their information written out and you can take a copy of it, put it in the chart, why not? And in your form, just say, look at additional information. And so then you have the update health history. You ask, is there a change? This is what I love my hygienists for. They always ask. They say, is there a change in your medical history? Is there something that we need to be aware of? And then as a natural dentist, patients seeking your care are more likely to be ill or think that they are very, very knowledgeable, and many of them are. Know your patients, ask why they are seeing you, and know your limits. Remember when Dr. Brockman said, hey, refer out? There's nothing wrong with referring patients to other doctors. And that's exactly what we said there. So always clearly mark all allergies. Ask about rubber dams, if it's a latex or whatever, what kind of metals, and your gloves. And then section for women, are they pregnant? Oral contraceptives do not mix with alcohol. Antibiotics. So if you're going to prescribe an antibiotic to a young lady between the ages of 20 and 35 or 40, you got to make sure that if you're going to do that, ask them, to realize that if they're on birth control pills, that may inactivate the birth control pill, and you might become Uncle Doctor somebody or Auntie Doctor somebody. So make sure the patient understands. The reason the patient's seeing you, what was their last dental appointment, and why did they stop seeing the last dentist? That really gives you a lot of information. And what was the patient told about their present diagnosis, treatment needs, referrals, and home care? So you get to interview the doctor, or the patient interviews the doctor interviews the patient, asks when their last cleaning was or their current restorations, and how can I, the dentist, help you? Then shut up. Don't say anything. Ask how you... Nobody ever asks a patient anymore, how may I help you? And that way you get to connect with that patient. Now, some people can talk for hours, so you may have to, guide that a little bit. But remember, shut up. Okay, there are many questions that you may ask. How do you want to position your practice? Are you going to go cosmetic? Are you going to go holistic? Are you going to go surgical? And medical, are you doing cosmetic procedures, treating cancer patients, IV nutrition, etc.? Position yourself. Questions direct patients towards treatment and care. So here we have a basic dental lineup for questions, our dental history, and then Do you have a computer management program? Why are you not utilizing all the computer offers? They have so many things in computers: Dentrex, SoftDent, toothpicks, Eagle, and if you look at Strawberry, they got a whole bunch of stuff out there that's amazing. You have flexibility and accessibility of a folder. We have to use a folder that folds out, and in fact, when we move to a new office, we're going to have 3 sections with 2 spots with pockets to be able to put everything in. Because now we're getting a lot of information from alternative physicians that I need to look at and read and know what's in that patient's chart. So there are sections for patient financial insurance information, supporting records, test results, office visit, x-rays, treatment proposals, signed consent forms. And remember, even if they don't want to take your treatment, you have to have them sign it that you explained it to them. And that's fine. And then, don't lose anything, of course. And then make sure always when you do this stuff, there are daily entries on that day sheet and the side pocket to hold loose things. Now, I don't know, how many people have a paperless office yet? Okay? You guys are the lucky ones. If you're using a paperless office, you lose it in the computer. Just make sure you get a double backup system. Are you taking pictures of the patient for your records? Blood pressure and oxygen saturation rates should be taken at every appointment. Actually, I just say blood pressure. When we're doing surgery, we always have the oxygen saturation plates. And the big one, the full set of x-rays, radiographs. There's so many doctors that miss those. And of course, as Dr. King said the other day, they don't even have it written in their chart that they took them. And I have the pleasure of reviewing charts for 2 or 3 legal offices in town. And they told me that they're happy that I'm not on the board because I catch more things than the board does. But I try to prepare them so how to protect the dentist that they're trying to represent. And the biggest thing I see is a lack of x-rays because they got lost. You got to make sure you don't lose anything and keep it. When you have these folders that fold instead of these pocket folders that drop everything out, it holds a lot more things and you don't generally lose it that well. And we're starting to see, I would be very, very surprised in the next 10 years if the old-fashioned x-rays are even used anymore in dental offices due to the dangers of the chemicals and everything else and the cost-effectiveness of digital x-rays. So you have a complete oral exam, existing teeth, missing, etc., periodontal conditions, temporomandibular joint, orthodontic classification, tongue thruster, do you need to refer them? And then this is basically what a existing chart looks like in a computer program with SoftDent. Each one of these is a symbol, like this tooth is missing, it's part of a bridge. It has a root canal, no restoration on top. I don't know why. Maybe that filling was supposed to be over. It tells us what it's made out of. But that's just an existing or initial conditions. And then it comes in and talks about the soft tissue. That's what's nice about a computer program. It guides you through and you can put everything in there. You can put the case type, pocket desiccation, mobility, what does the x-ray show, and then you can come in here on a hard form and do the exact same thing if you don't have a computer. Then you got your progress notes. So same information for your patients, but records will reflect the type of practice you have. Organize your chart for easy retrieval of information. Always have the patient sign consent forms before you begin treatment. You may not guarantee results. That's really, really important. Before we do a filling, and I don't have this information in the lecture notes, we have a consent form that tells a patient that any time that you work on a tooth may die or need further work. If we're doing a crown prep, there's a possibility you may need a crown lengthening. You may need a buildup. And that is in a consent form that the patient signs before we get started. Informed consent is very important. And with perio, there is never an end point. Patients must have a periodontal appointment in our computer or on the books every time they leave the office. Even if we're sharing this patient with a periodontist, we want to get that next visit in there. And doctor-patient communication leads to patient treatment plans. How do we make a living? These are the basis for informed consent. A written treatment plan is a focal point of doctor-patient discussion and patient decision to treat or not to treat. And organize and prioritize the treatment. Give an estimate of cost of care and maybe time. This is not always possible because you may have somebody, you don't know how long they're going to recover from surgery, etc. So you have to give estimates. Guide through the information the patient needs to understand before informed consent can be given. and assist the staff to properly schedule the appointment. This is one of the biggest obstacles for some of our patients getting their care, because the doctor is so busy and they're trying to move people in and out. Docs, you got to tell your staff what's next. They are not mind readers, believe it or not. So assist the staff to make referrals to specialists, assist the staff to properly set up treatment rooms for patients for their visit by telling them what's needed, and then assist in collections of fees, send out the appropriate insurance forms, but make sure that the patient knows what everything costs. I never talk money with the patients. So when the patient goes up and says, well, I took care of that with Dr. Margolis, he said it's okay. They know they're lying. They know it's a lie, because I'm not allowed to talk about money because I don't know anything about that. And serves as evidence in defense of a peer review, patient complaint, or professional liability action. So treatment plan options, give them options. You can have something like this. It comes through. It's got a nice little picture here. Blue is for proposed work. And you come in here, or blue was the finished work, red is proposed work. But you have this, and this is very old because these aren't the fees anymore. But you have everything laid out, what the service is. And then we have a surgery down here. And then we come in. On the bottom, I have read and understand this dental treatment plan as presented to me on, you've got the date. You got the guy you talked to, explain and review the treatment plan with me. I acknowledge that this treatment plan represents his or her best recommendation for my dental health. I will go through the procedures. My office staff goes through the money. Don't talk money to your patients. You're more interested in talking to them about services, what they need. Let them collect the money. They're the ones collecting it, and don't make any deals with anybody. The ones that you make deals with are the ones that are going to complain about the service they got. The ones that pay full fee, they're the ones that never seem to complain. Just remember, no good deed goes unpunished. And then you have a patient over here, their signature, the doctor's signature and date. Make sure your signature is on that. That shows that you were with the patient and vice versa. Radiographs, prior to seeing what the new digital x-rays can do, this is not enough. I can't see the periapicals up here. They're not giving me any information. On the new digital panoramic views, you can see better detail than any of this will ever give. But if you're using traditional x-rays or using a phosphorus screen x-ray that is used for digital x-rays, this is not enough. You have to have 12 to 14 x-rays to show everything. Know your supporting records, laboratory, medication, material reactivity testing, correspondence with other doctors, and after-hour telephone conversations. I actually write down, if I do a prescription for somebody over the weekend, that I write the stuff down and then we enter it into their chart. The backbone of your records, your daily progress. There's no standard form for progress notes, but if you go with SOAP, action, subjective, what did the patient, objective, action, assessment, and plan. And the reason I did the 2 A's there was because patients' biggest complaint is that doctors don't listen. They don't do things. They don't tell you. Perception the doctor doesn't care, let's just get the procedure done. And that's really, you get people pushed through, and they avoid the perception of indifference and promote partnership rather than adversary. If you take your time, you've explained everything, the patient knows what's going on, now there's good communication between the two. Partnership leads to high quality care and avoids potential problems in the future. And always there's an entry date. Always make sure you date it, please, and sign it at the end. Subjective is what the chief complaint is. What's the patient there for? Derived from the mind or inner feelings of a person. What does the patient feel? Where does it hurt? How long does it hurt? Is it better or worse? This is what the patient relates. Now, objective is what do you see? What do you find? What do your x-rays do? Write down, did you pound on that tooth? Did you do an electric pulp test? Or if you're looking at somebody, you can put down their blood pressure and everything else that you go with their oxygen saturation. That's objective. You measured it, you put it in your chart. Make sure it's all there. And note all radiographs, biocompatibility stuff. This is what the doctor observes. Now, you're going to take an action from that. Now, I might have this backwards because the assessment is done, then you have action and assessment again. Provide the treatment plan rendered, all aspects. If a patient is pre-medicated, note that that's done. Make sure you check. All materials used. Put down who the manufacturer of that material is and the name of the material. Or if you just know the name of the material, that would be fine if that's just the manufacturer. But don't put down Reliax. Reliax, there's 8 different Reliaxes. Make sure you know which one you're using and you put it in your notes. That's a type of cement. So actual treatment rendered and plans for the next visit, because I got to put down the plan for the next visit and the assessment. What happened? Was the service okay? So I put down in there patient, even if it's a filling, I'll write down there, patient did well, something. Adjusted the surface for bite or occlusion. So provide that objective information there. Once treatment began, did the diagnosis change? Gee, I went in there and I was going to put a temporary IRM in there, but there's an exposed nerve. Patient wants time to decide, do they want a root canal or do they want an extraction? So I temporized the tooth. That wasn't what I planned to do, but that's what happened. But I also had a consent form stating that they had that possibility of that occurring. So I already had the informed consent that they realized that there was that opportunity that I didn't want to happen, but they were informed. And I write that in there. How confident are you about your prognosis? And did the service you perform meet the needs of the patient, or did we need to do something else? And the plan, what's next? Next visit, let's get going. So it's a SOAP. Okay. So what do? Top of the page, patient name on that daily sheet. Make sure it's there. Left-hand corner, we're going to have a date and subjective patient complaint, no pain, tooth has fractured, location, name of the patient, they're anxious, whatever, they're worried about it, they're worried about finances. Make those notes in there. So I put in there that this is the tooth we did. I had their blood pressure. I inspect before I inject. In other words, I get a blood pressure before I inject them with a anesthetic. Why? Would you do surgery on somebody in a hospital if you didn't have a blood pressure before? Oh, I'm going to take you down to the operatory or operation room. Oh, we forgot to take your blood pressure, but we pumped you up with all these drugs. Hey, you're pumping them up with a drug. How many people are using epinephrine these days in dentistry? Anybody? Shame on you. Pardon me? I wouldn't use Septicane. I'd use something else. No offense. I don't mean to down talk anybody, but let's do this. I can't run anymore. I got bad knees, but I'd challenge you, if I had good knees, to run a 100-yard dash, only you're not allowed to breathe and I am. That's what you're doing when you're using epinephrine. And I could show you multiple surgeries that I do with no epinephrine. And it's amazing. I get plenty of anesthetic and plenty of time to get everything done. And if I have to, I will re-inject. But you're cutting off the oxygen to a tooth if you're using epinephrine. And then start writing down how many of those teeth, if you crown them, I'd say 20% will die within 5 years or need a root canal or an extraction. Take your pick, because of epinephrine. That's personal opinion. I have no scientific data on it other than the fact that that's what I was seeing when I was using epinephrine. I don't like this stuff.
What do you use primarily?
I'll use Meprocane, Polocaine, Carbocaine, Cetines, and those come without epinephrine. So we have all those. By the way, I do have epinephrine in the office. I have used epinephrine in the last 5 years 3 times because of bleeding reasons. And that there's a place for it, yes. But for routine work, I don't think it's a smart thing to do for your patients. So we put down what we were doing, have a written treatment plan, which we had that was signed before, pain a pound, this is what happened, it's the objective. And then we go through, we write what we did and everything else and sign it off. Informed consent, treatment plan, etc. We can go right, complications, benefits. Okay, so I write in the anesthesia. I should have had a blood pressure before that, which was 2 slides ago. Prepared 19, told what I did. I put a temporary crown, the type of material I used, cemented with Tempon NE. We've been going to zone, and I used the Pentamix impression material. If I'm using nitrous oxide, you write down when you start, when you finish, and the concentrations, something like that. And then assessment, how did the patient do? Patient tolerated procedure very well. Patient was very anxious. We used nitrous oxide. And then I put down next visit. Patient is due for cleaning, exam, whatever, because we just did a filling, not a crown. And this is a gentleman, Dr. Durlacher, is an 80-year-old chiropractor who deals with anxiety. So I referred the person for anxiety. He uses a tapping system and has worked very well. Protective health information. This is dentists must have a written policy, privacy, and appoint a staff member. This is in your HIPAA notes that you should know that. There are a number of people. We have a lady that comes in once a year, updates this, but it's called Protective Health Information. And April 14th, 2003, HIPAA privacy rules to regulate the maintenance, transmission, security, and privacy of personal health information, rule or designed to regulate, and this information is called the Protective Health Information, and HIPAA privacy rules for patients have the right to gain access to their records and request corrections or accounting of any unauthorized use of the PHI. And dentists are required by law to have this, the protection against unauthorized use, and to gain written consent from patients before disclosing any protected information. Dentists must post a notice visible in your office to inform patients how they might use or disclose personal health information. It's personal, so we don't do it. And according to the information publicized by HIPAA, there are fines including up to $250,000, as much as 10 years in prison to dentists or other health professionals in violation of HIPAA privacy rules. I think that's a little stiff, but this is what I was running to get to in this slide. If you want to get a starter kit for HIPAA, it's very easy to get. It's in Wisconsin, and go from there. Anyway, the last slide I'm going to cut off here because I want to keep the conference on speed. If you advertise and you are a general dentist, you need to put down services provided by, here it's an Arizona licensed general dentist. In New Jersey, there's a special saying there. And in other states, if you're a general dentist and you say that you do crowns and you do gentle dentistry, you have, unless you're a specialist, you have to state that all services are provided by a licensed general dentist of your state. That lesson cost me $5,000. I'm giving it to you for the cost of what you pay for this entire conference. And it'll be worth it if you advertise. On any pamphlet that you put out, anything that you advertise, always put down that you're a licensed general dentist of that state. Check your rules. They're very simple. The one thing that Dr. King told us at the very beginning was, do you have a rules book, your regulation statute book from your state board, and why not?